Welcome all to the ERC webinar on extracorporeal CPR. My name is Soar. I'm an intensivist in Bristol in the UK, and I chair the ERC Advanced Life Support Science and Education Committee. I'm the co-chair of that, and it gives me great pleasure. We've got 5 excellent speakers, and I'm going to get each of them to introduce themselves, and then we'll move on with the program. Please look at the Q&A box on your Zoom screen, and you can put questions in there as the webinar goes on, and I'll be able to see those and pick out questions and ask them at the relevant part. So they will have questions after each speaker, and then we'll have a closing Q&A session at the end, and I'm hoping we get done in 60 to 75 minutes. So I'm going to start by welcoming our first speaker, or our first panel member, Alice Hutin from Paris. Just tell us a bit about yourself, Alice.
Hello, everyone. Thank you, Jazz. Thank you so much for the invitation. My name is Alice Hutin. I'm an emergency physician in Paris at the SAMU, which is our pre-hospital emergency medical system. And I'm very happy to be here to talk a little bit about our pre-hospital ECPR program.
Right, welcome. And our second panel member is Ingrid Magnet from Vienna, Austria.
Yes, good evening. Thank you very much for the invitation to this webinar. I am an intensivist working at the University Hospital Vienna, and also an EMS physician working at the EMS service in Vienna, and I lead the Vienna ECPR program.
Welcome. And then we have Maria Martinez from Barcelona.
Thank you for the invitation. My name is Maria Martinez, and I am an intensivist from Barcelona. I am a part of the ECMO team in Vall University Hospital. We have an ongoing ECPR program since some years ago. And also related to this, I have some experience with pre-hospital medicine before I worked full-time in the hospital.
Right, welcome. And then we have Jan Bělohlávek from Prague, in Czech Republic.
Thank you very much, yes, for introduction and for invitation. My name is Jan Bělohlávek, and I'm a cardiac intensivist and interventional cardiologist from Prague, Charles University Hospital. And I'm current chair of the also ECPR working group, and I'm performing ECPR for past about 12 years.
Welcome. And the final panel members, Tommaso Scquizzato from Milan, Italy. He's also going to be our first speaker, and he's going to start off by setting the scene. And before we talk about CPR, I'm quite keen to understand, does it actually work? You know, is it worth our effort doing all this? So Tommaso, introduce yourself and explain to us the evidence or the lack of evidence for ECPR and whether it works or not. Thank you.
Hello, everyone. I'm Tommaso Scquizzato from Milan, Italy. Thank you for the invitation to the ERC for organizing this beautiful webinar. And I work in the cardiothoracic ICU in a big ECMO and cardiac arrest center in Milano, and we do ECPR since 2013. And I'm happy to start and give you a short but very interesting presentation about the current evidence of ECPR. I'm waiting for the slide. Okay. And so currently, advanced life support is the standard of care for patients with a cardiac arrest both outside and inside the hospital. And outside the hospital, we know that when a patient is suffering a cardiac arrest, high-quality CPR defibrillation, obtain a vascular access and administration of drugs, and airway management is the cornerstone of treatment. And we know that when we do this very well, we are able to achieve a good survival, good outcome, especially when combined with early basic life support. When the patient is in refractory cardiac arrest, however, means that this is not working. Basic and advanced life support conventional CPR is not working, and so we know that very few interventions are still available for this kind of patient. So you can see a list of interventions that typically we see in the guidelines. We typically see randomized trials showing some kind of benefits, and the remaining intervention for patients in refractory cardiac arrest are currently ECPR and alternative defibrillation strategies that show to improve survival. But before continuing, it is important that we define what is a refractory cardiac arrest. In the last 20 years, probably changed many times. Initially was a definition of 20-30 minutes without return of spontaneous circulation. Recent trial defined refractory cardiac arrest using a shorter time frame, such as no return of spontaneous circulation after 3 defibrillations, 5 minutes of advanced life support without return of spontaneous circulation, or 50 minutes of resuscitation without a return of spontaneous circulation. Using this definition, we know that less than 10% of out-of-hospital cardiac arrest are considered refractory and at the same time eligible for ECPR, meaning that ECPR is still and will be an intervention reserved to a small proportion of patients that we treat every day outside the hospital. And so alternative defibrillation strategies and ECPR are the 2 interventions we have for refractory cardiac arrest patients. And we know that still with alternative defibrillation strategy, less than half of patients are able to achieve return of spontaneous circulation, so remains in cardiac arrest. And so even in this moment, the last opportunity we have is ECPR. And so we can divide the duration of a cardiac arrest in a time point when we have to switch and change our strategy. We have a period of time where we can attempt with conventional CPR and probably adding alternative defibrillation strategies, but at a certain time point, we have to switch as the only intervention we have that demonstrated to work is ECPR. And so we have the ARES trial, that is the first trial that demonstrated a huge effect in improving survival to hospital discharge and at 6 months in patients with refractory out-of-hospital cardiac arrest. As you can see, enormous success, and at 6 months, nobody survived with conventional CPR. And then we have the trial conducted in Prague, and I'm sure that Jan will talk about it later. And we see that here there is a statistically significant difference in survival with good neurological outcome at 30 days, and a non-statistically significant difference, but numerically similar at 6 months. When we compare patient in a shockable rhythm, we find also a very huge difference, but does not reach statistically significance. And if we compare patients that had a cardiac arrest with a duration more than 45 minutes, here we are able to find a statistically significant difference at 6 months in good neurological outcome, 22 versus 8%. And if we compare patients that did not achieve ROSC and received just advanced life support, and the patient that did not achieve return of spontaneous circulation and were treated with CPR, we see a huge difference in this secondary analysis of the Prague OCA study, 22% compared to 1%. And then the Inception trial came. This is the first multi-center trial conducted in the Netherlands, 10 different cardiothoracic unit, and they randomized patients with an initial shockable rhythm. And unfortunately, this trial different from the previous one because the difference was very, very small, 20% compared to 60% in survival at 30 days with a good neurological outcome. And the difference was not statistically significant. This 4% difference was not statistically significant. And one of the main observations from this trial is that, especially compared to the other trial, are the timing of intervention, meaning that in this multi-center trial, time to hospital arrival was shorter compared to the other, but the time needed to establish from hospital arrival to establish ECMO flow was 3 times higher. And as you can see, 12 minutes in the other 2 trials and 36 minutes in the Inception trial, and this 36 minutes was composed by 60 minutes from the start of cannulation and 20 minutes for cannulation. And the results of this increase in time led to a higher duration of low flow time compared to the other trial. As you can see, 74 minutes of low flow. And if we compare and combine together all the trials in meta-analysis, we are able to still demonstrate a statistically significant result in terms of improving survival with a good neurological outcome and improving survival, especially in patients with initial shockable rhythm. When we consider if ECPR is working, we can't ignore that patients treated with ECPR frequently and to a higher extent going to brain death, for example, and so open opportunity for organ donation. And this should be acknowledged and considered when analyzing ECPR outcome. As you can see, this is the case series from my institution, and 19% of patients donated at least one solid organ. And if we compare and combine the outcome in a composite outcome that include patients that survive with a good neurological outcome or donate at least one solid organ, we achieve a 28% of overall benefit, meaning that we were able to help 29 patients with good neurological outcome and 177 recipient of at least one organ donated from an ECPR patient. And so I think that this is important to consider, especially because organ donation and organ transplantation is also very important from a cost effectiveness point of view. And to conclude, in addition to the discussion if ECPR works or not, it is important to consider that the implementation of ECPR for sure in my center allowed to better study patients with cardiac arrest because we became exposed to a completely new type of patient. Typically, we were exposed to patients with a median of low flow time of 20 minutes to a median low flow time of 60 minutes, such as ECPR patient, and probably allowed to push the boundaries of how long a patient can survive a cardiac arrest. And overall, I think all the EMS team in hospital and out of hospital professional had a benefit of from a point of view of education and investment and group professional growth in building and maintaining an ECPR program. And to conclude, my take-home message is that ECMO from a mechanistic point of view is something that is feasible in cardiac arrest and works, meaning that you connect a patient to ECMO and ECMO works and is able to restore the cardiac function and circulation and perfusion. And in some high-performing systems, as demonstrated by the trials, ECPR can improve the outcomes. And we probably still don't know how large is the effect size because compared to the single center trial performed in very expert centers compared to implementing CPR in different centers with variable experience, the effect size was smaller. And still, ECPR has a level of evidence that is similar or even higher to other advanced life support intervention. If you see the guideline, the recommendation, and the level of and the certainty of evidence, it is similar to other intervention. And I think that the most important take-home message is the last one. ECPR ECMO currently is not able to revert a severe brain damage. And if we want to implement ECPR in a system, it is important that we invest in the system and especially in the reduction of no-flow time through bystander CPR and bystander defibrillation. Thank you for your attention. I'm happy to take questions.
Myself. Thank you, Tommaso. We don't have any questions on the Q&A, and I think we should just move on with our next speaker. So remember, if you want to ask a question to the speakers, the panel, you need to go to the Q&A on your Zoom screen and type the question in that, and then I'll be able to see it and ask the panel. What we're going to do is move on to our next speaker, Ingrid, and there'll be plenty of time for questions towards the end, okay? Or we'll get some questions after her talk, because I'm sure there's going to be quite a lot of overlap between the talks. So thank you, Ingrid.
Thank you, Jas. So now that we established that ECPR works, we have to talk about who it is working for. I have no financial conflicts of interests. I introduced myself briefly, but just to show you that is what Vienna looks like. We are the red dot. We cater to about 3 million people in total, including Vienna and some of its surroundings. We have a very beautiful hospital, the Vienna General Hospital, which was built in the 90s, and this is how long we've been caring for CPR and ECPR patients. We are a certified cardiac arrest center, and we have around 300 resuscitations, and out of these, around 70 ECPR patients per year. I myself, as I said, I work in hospital as a consultant for intensive care medicine and pre-hospital as an EMS physician. So although we in Vienna only do in-hospital ECPR for out-of-hospital cardiac arrest, I do treat cardiac arrest patients pre-hospitally. So who is ECPR for? This is a statement that's already a couple of years old, but I think the idea has been the same since then. So it's a rescue attempt for highly selected patients in refractory arrest with a potentially reversible etiology of arrest. And this is pretty much the same what the guidelines say. So in select patients, if feasible, we do ECPR when conventional ALS is failing. Now let's break it down. So selected patients or patient selection. These are some common selection criteria that are used currently all over the world to choose patients or to select patients for ECPR. This study was very nice because it compared those selection criteria from various studies across a collective of patients and how different selection criteria affect the patient outcome. So there are things like age and timing, cardiac arrest characteristics like witnessed arrest, bystander CPR, and etiology characteristics. And we look at the data, there can be more restrictive or more liberal selection criteria. And this affects your patient outcome. So if you have more liberal selection criteria, you have the risk of having a higher mortality rate. If you have more strict selection criteria, you will have a higher survival rate, but you might actually miss survivors, as was actually shown nicely by this study. So there is not a thing like choosing the perfect patient for ECPR that will certainly survive, or being certain that this or that patient cannot survive with ECPR, but there is a balance that every system will have to choose where they will place themselves on this scale. And this is true for out-of-hospital cardiac arrest, and this is even more true for in-hospital cardiac arrest. So our current set of selection criteria cannot 100% choose the perfect ECPR patient. They will either miss survivors or they will risk a higher mortality rate if we are more liberal. Now, the second thing, as Tommaso pointed out, refractory cardiac arrest. There is currently no common definition what actually is refractory cardiac arrest, and I think Maria will go on to that point of timing as well. The guidelines are pretty general. One statement from the AHA actually put a number there, 10 minutes of CPR. And when we look at the studies that actually studied ECPR, they had also a varying set of definitions of refractory cardiac arrest, from 3 shocks to 10 minutes to 20 minutes of failed CPR, depending on which study you look at. And the third thing, reversibility of the cause of arrest. Now, this is a very nice statement, and it is certain that there are things that we can treat more easily, like cardiac causes of arrest. We can reopen the coronary artery, and then hopefully the patient has spontaneous ejection of their heart and can be weaned from ECMO. But then there will be causes of arrest that are more difficult or even impossible to treat. So cardiac causes, pulmonary embolism, accidental hypothermia, poisoning, they have good outcomes and are what we would like to treat with ECPR. And there is other causes of arrest that are simply not treatable, like acute type A aortic dissection or primary cerebral disorders. Unfortunately, at the time point of selecting our patients, we often do not know. We will not know what the cause of arrest has already been. So one thing of choosing patients or of selecting patients is primary rhythm. If you pick ventricular fibrillation only, you have a higher chance of selecting patients with cardiac cause of arrest. Whereas, for example, if you also select patients with pulseless electrical activity, you will have a lot of other causes of arrest in your bundle of patients, and this will, of course, influence outcome in your center or in your patient population. To sum it up, this is what the selection card in Vienna looks like. I guess every center has something similar. So we choose patients that have been 10 minutes in at least 10 minutes, received 10 minutes of advanced life support, or select for them within 10 minutes of advanced life support. They should be fit and healthy, however you want to phrase that, so not be frail, have no life-limiting diseases, and we have an age limit of 70 years, but these vary between systems. There has to be a strong and seamless chain of survival. Just as Tommaso pointed out, we cannot revert any brain damage that has happened before. And there has currently to be the logistical possibility to make ECPR happen. For our center, for example, this means that the center has to be reached within 40 minutes of cardiac arrest, and there has to be mechanical chest compression possible. Some of these factors cannot be influenced, like the type of patient. Some patient factors cannot be influenced, but other factors like the witnessed arrest status, the immediate CPR, or logistical things can be influenced because they're system factors, and that's where we can, I think, as a community, work on to make ECPR available for more people. And with that, I will hand over to Maria, who will tell us when we should actually go on to ECPR.
Great. Thank you, Ingrid, and welcome, Maria. Before you go on, I've just looked at a couple of questions. So if you want, this webinar is being recorded, so you will be able to watch it again on the ERC. Someone's asked about children and neonates, and we're primarily focusing on adults on this webinar, but clearly, there's fewer studies in children, but people are using ECPR in children. So carry on, Maria, please. Thank you.
Okay, thank you. And thank you, Ingrid. I think there will be minimal overlap, and I am very glad that you covered some things in your presentation, so I can move on to the more philosophical questions of when to initiate ECPR. So I will try to answer this question from both a very conceptual, maybe idealistic point of view, and also a more realistic, down-to-earth point of view of what can be done with the technology and the means that we have, what is feasible and what could be ideal. So from a conceptual point of view, we all know that the aim of CPR, conventional CPR, is to partially substitute circulation until spontaneous circulation is restored. And we also know that when VA ECMO is successfully initiated, circulation is immediately restored. So it could be tempting to say that we should initiate VA ECMO as early as possible, because that way we will be out of the arrest. However, everything is a matter of balancing the risk or the risks of a therapy with the benefits of the other. And we know that initiating ECMO is not logistically nor not a technically easy task, and that transferring patients for ECMO may put them at risk of lower quality of CPR. So in this study, Grunau and collaborators tried to answer these very same questions to find the optimal moment for transferring patients without putting them at risk of not achieving spontaneous circulations due to many causes, but some of them like lower quality of CPR. And they saw something quite interesting, that by minute 8, this is a study of a prospective cohort. These patients were not transferred for CPR. There were just potentially eligible patients. That by minute 8 of CPR, the possibility 50% of the patients that could achieve ROSC had already achieved ROSC, and that for minute 24, 90% of the patients that recover spontaneous circulation had already done it. And they also found a moment that maximized sensitivity and specificity of being pulseless as a predictor of non-survival, which was around the 16th minute. So patients that do not have circulation by minute 16 have a very low possibility of recovering spontaneous circulation with conventional CPR. This is also seen earlier in other group of patients, and the duration of resuscitation affects the functional outcome. It is difficult to survive with good neurological outcome defined of a modified Rankin scale of 0 to 3 for patients that have ongoing resuscitation past minute 20. So we know that we could say that conventional ALS is failing in the minutes between 10 and 20 minutes of CPR. And how does ECPR influence the possibility or the yield of resuscitation? Like how does ECPR modify these possibilities of survival depending on duration of CPR? So this is a sub-analysis. This is an analysis of the Prague OCA study in which we see the proportion of 180-day like febrile neurological outcome depending on duration of resuscitation in the invasive, that means ECPR, versus the standard arm, and we see that ECPR increases the yield of resuscitation. This allows patients to survive past the point of non-survival with conventional CPR. It can be extended up to 75 minutes, but finishes at around 80. So when the patients have almost no possibility of survival with conventional CPR, that could be around minute 40, there can be still good possibility of survival with ECPR. Realistically, because with all that we have seen before, we see that VA ECMO initiation, so ECPR early in resuscitation can yield good outcomes. Realistically, we know that emergent VA ECMO initiation is a complex intervention, and that complications derived from cannulation may impair survival in patients that might have a good outcome with conventional resuscitation, and also that ECPR is not a technique, it's a system intervention that involves many steps. Since the early resuscitation, as the former speakers have already said, to the transfer of the patient to the hospital, the in-hospital logistics, and the cannulation process. And this may not be immediately available for all patients. Everybody that has treated patients in cardiac arrest out of hospitals can see the logistical problems of transferring patients to hospitals. I would put an example, like patient in cardiac arrest that detected early resuscitation by bystanders. Realistically, EMS can arrive there, depending on the population area of the city, around 5 to 10 minutes, depending on the area. Then you need some time to initiate the treatment of the arrest, defibrillation, if you use mechanical chest compressions, intubation, and you are ready to move the patient at around minute 10. If we look at the times in the two biggest clinical trials, the median time from collapse to hospital arrival was around 44 to 60 minutes, only for ECPR patients in the Prague study, and around 36 plus minus 12 in the Netherlands study. And the time until cannulation was around 43 to 70 in one of the studies, and between 63 to 86 in other of the study. So although conceptually it makes sense to try to initiate ECPR as soon as possible, logistically and realistically it may take some time until we can do it for out-of-hospital cardiac arrest. What happens with in-hospital cardiac arrest? There is a nice observational study that includes around 1,000 ECPR in-hospital ECPR patients for in-hospital cardiac arrest, in which it can be seen that the low flow duration impacts the outcome of the survivals the low flow time is significantly lower for survivals than in non-survivals, and they see that there is a drop of about 3% in survivals every 5 minutes. So this challenged the assumption of waiting until initiating ECPR until we have decided that this arrest is refractory in hospital cardiac arrest. So to answer the question of when to initiate ECPR, we can go conceptually, and in my opinion, if we could start ECPR with a snap of our fingers, it should be as soon as logistically possible for refractory out of hospital cardiac arrest. This would be like more than 3 defibrillation or 10 minutes. We have seen how survivals decrease after the 10 to 20 minutes mark. And if we start thinking about ECPR at that moment, we are going to be arriving at the hospital at the times that we have seen in the studies, but because there are logistical constraints that cannot be bypassed. They can be improved, but they cannot be bypassed. And immediately for in-hospital cardiac arrest, especially if we know that there is a known low survival reversible cause, like pulmonary embolisms or if there is complications in the cath lab. Realistically, and going back to Earth from this very idealistic point of view, we should aim for low flows as low as possible. They are directly related to survival and should be lower than 45 to 60 minutes in out-of-hospital cardiac arrest, and ideally much shorter for in-hospital cardiac arrest. Okay, thank you. And I will answer any questions or comments.
Yeah, thank you, Maria. So just remember, put your questions in the Q&A box. I do have some questions lined up, and I was going to put the first one to Jan. So Tommaso presented us the trials, and the question is do patients, are you potentially making the outcome worse for the patients who are receiving standard conventional CPR by transporting them to try and get them to an ECPR centre quickly? You need to unmute yourself as well again. Thank you.
Yeah, sure. Sure. Thank you for the question. That's a very typical question we are receiving always when talking about the ECPR, and it's based on the analysis by Brian Grunow from the large American-Canadian registry of almost 20,000 patients, showing that intra-arrest transport per C might worsen the outcome. There was 4 versus 8% survival. However, if you look carefully in this analysis, you would see first that in this trial, which was not a randomized trial, there was no systematic use of ECPR in those patients. And the second, so meaning patients were transported under ongoing CPR to hospital, but they were not offered with the ECPR routinely. And second, even in this trial, if you look at the subgroup analysis, you will see the subgroup of patients with a resuscitation over 30 minutes who actually had a benefit from the transport to hospital under ongoing CPR. And most importantly, Maria has shown our analysis, which was actually performed by Brian Gruno on our own data. We did it together. And he has shown that when we analyzed our data with the dynamic probability of survival, exactly as Maria pointed out, then we have shown that the transport actually doesn't worsen the outcome. And the outcome in those patients who at the end achieved ROSC was the same in both arms. And those who did not, they had a large benefit from ECPR.
Great, thank you. One more question, I think, for Ingrid. Remember to unmute yourself. Now, someone's asked, so what, you're giving you 3 shots. Should you be going to a double or dual sequence defibrillation, or should you be going to ECPR? You know, has anybody compared the two? And Ingrid.
Thank you, Jess. I'm not aware of a study directly comparing the strategies. However, I would like to point out that this is not a question of either doing high quality ALS or doing ECPR, but rather these things are sequential. So you try to optimize your ALS with everything possible. And if your system allows for double sequence defibrillation, definitely go for it. However, if all these optimizations fail to achieve ROSC at the end of a perfect chain of survival, if the patient is still in arrest, there is the option of ECPR. So the two should not or cannot be played against, but you have to make everything happen to achieve either ROSC, and if that fails, you have ECPR as an option to achieve at least circulation to manage the course of cardiac arrest.
Right, thank you. Maria, I was going to, you've got your hand up, so you may have a comment, but I was going to also ask you a question. So you said very early ECPR in hospital, and someone's asked, well, does that mean we should be going for ECPR for all in-hospital cardiac arrest over conventional CPR?
Okay, first I wanted to make a comment about like the dual defibrillation, and the thing is that we maybe should be aiming for that, but early in the cardiac arrest when it is more likely to work. If you are already in a refractory phase, probably it's not the best like to waste time in hospital trying to do the double shock when you are in already a metabolic phase of the cardiac arrest, but very early in cardiac arrest, probably yes. Then should we go in for ECPR in all in hospital cardiac arrest? Well, depends, because all is a very broad statement. First, the patient needs to be eligible with a reversible cause. We know that many times cardiac arrest in hospital is due to progressive deterioration, and this might not be reversible. But in a set of patients, for example, patients with a very high suspicion of pulmonary embolisms, or patients with a diagnosed pulmonary embolism that go into arrest, we know that low flow in those patients is very low quality due to obstructive shock, and also that fibrinolysis might not have the best results. So yeah, I would go immediately for ECPR in those patients. The same, well, maybe Jan is more experienced in this part, but for a patient that arrests in the cath lab, for example, with a left main or something like that, possibly it is reasonable if you have the immediate possibility of going for ECPR, just to go for ECPR.
Right. We're going to pause there because there's quite a few questions about, you know, should you do the ECPR at the scene, or how do you do the transport, and what do you do when you get to hospital? And luckily, we've got 2 people to answer those questions. So I'm going to go to Jan to talk about delivering ECPR in hospital, and then we'll have Alice who will talk about starting ECPR out of hospital.
Okay, thank you very much. So I think there's a different ways how to do it, and I think at the moment we don't know which one is better, but I think both have advantages and disadvantages, and that's good to discuss and maybe get inspired one from the other. If you let me... Okay, so I have just a disclosure that I was the PI of the Prague study, and I cannulated more than 250 patients over those 13 years. So I'm kind of biased, and I've seen many patients surviving that didn't survive. And this is the typical scenario from our cath lab, how it looks like actually during the ECPR. So this is a very typical patient who has had a 9 unsuccessful defibrillation in the pre-hospital setting, was brought to the cath lab under mechanical CPR and put on the table. And as you can see on the table, the mechanical CPR actually works pretty well and saves the hands of the personnel. And during this ongoing CPR, the femoral vessels are cannulated with a large bore cannulas and put in, and as you can see over here, once we have extracorporeal circulation, we search for the etiology of cardiac arrest. So this is how it's being done in our center for past 13 years. And the system works this way. So there's one central dispatch center in Prague City, which is covering over 1.3 million people. And if there is a witnessed cardiac arrest alerted to the dispatch center, the EMS is being dispatched to the witnessed cardiac arrest, and telephone-assisted CPR is being started in more than 80% of cases. And at the same moment, if the cardiac arrest is confirmed by EMS, there is a very early alert to ECPR center by a fast mobile app. So basically, we got alerted that there is a patient who is being resuscitated. So we know very early during the cardiac arrest. And then if the inclusion criteria for possible ECPR track are being confirmed, so meaning that the refractory cardiac arrest is confirmed, then the patient is loaded and under intra-arrest transport is being transported, eventually cannulated for ECPR if not achieving ROSC during the transport or early after admission. And then the patient undergoes, of course, comprehensive post-CPR care, including early neuroprognostication, and then if survives, gets into the outpatient clinic for multidisciplinary follow-up care, because a lot of those patients need a specialized care, hoping that a significant proportion of the patients get back to life. So this is how the system works. And the prerequisites for a successful ECPR, of course, is a very robust ALS system or pre-hospital system. So if you look to the data from our trial, you can see that we enrolled majority of ventricular fibrillation patients, but most importantly, basically all the patients did have a bystander CPR, and 80% of cases were with a telephone-assisted CPR. And I'm deeply persuaded that this is the most important part of the system, that the patient gets immediate bystander CPR and eventually, of course, early defibrillations to get the ROSC, because this is the best you can do. And I'll show you in a couple of minutes how this important is. And then the decision has to be very fast. So in this trial, we decided within 25 minutes of CPR whether the patient is going to be randomized to invasive or standard. So 10 minutes to get on scene, 10 to 15 minutes for the initial resuscitation, and then decision and transport to hospital. And this is the Prague area. You see this is covered with the blue pins. This is the EMS stations. The circled ones are those with a physician, and the hearts are the centers which are able to provide ECPR. Our center is in the city center, is the largest center for cardiac arrest, and you can see that the coverage is quite even, and the transport times are reasonable for our center. And we use this app, as you can see on the screen. This app is being provided by EMS, and it started at the dispatch center, alerting us on the middle with an early ECPR alert, asking for the question whether the center is ready. And if one of the centers is not ready, then the other center can cover for the previous center. So the EMS gets a response from the ECPR centers whether they are willing and able to accept the patient under ongoing CPR for possible ECPR, also depending on the place where cardiac arrest has occurred. And then we start a very fast communication on how the patient looks like and whether the patient is still being a candidate for ECPR. And in the meantime, of course, we prepare cardiac cath lab for admission and staffed with both devices and the team. The team usually consists of 5 to maximum of 7 people with intensivist, usually 2 cannulators, interventional cardiologist, ICU nurses, cath lab nurses, perfusionist, and the data manager who collects all the data and, of course, all the responsible devices. But this can be very well done at the ER as well. The concept of cannulation, as has been already shown, is the concept of speed. So we have to be very fast with transport and cannulation. We have to be safe. Therefore, we prefer the home ground of cardiac cath lab for cannulation. And of course, it has to fall actually into the properly functioning system. So for the emergency cannulation, we need to have effective teamwork. So there is no place for improvisation. Everything has to be trained and simulated. Everybody has assigned roles. So the cannulator, the intensivist, perfusionist, and nurses. We always use a guided, safe approach. So to assure that the cannula is inserted into the proper vessel, usually ultrasound guided, X-ray followed insertion of the virus, and of course proper cannula attachment to avoid disconnection, and distal perfusion cannula is being performed at the end of the procedure. So a little back to the trials that have been mentioned by Tommaso. So the first trial was ARREST 2020, just 30 patients. Our trial was the second one, 256 patients, and the last trial with 134 patients. What those trials said, actually. So if we look at the effect of ECPR, I'll just turn to first 2 trials. Our trial has shown nicely that if you take our own data from the trial and you look to those patients treated with ACLS and who achieved TROSC, you can see that 65% of those patients survived well. So it's important to state that it's the best in out-of-hospital cardiac arrest to achieve the ROSC. So we have to let the patients have a chance to achieve ROSC. So not to start the transport too early, but not to also start too late. So those 20 to 25 minutes, I think, are enough to achieve ROSC for a significant number of patients. But those patients who remain in cardiac arrest definitely and never reach ROSC are exactly patients who may benefit from ECPR. And you can see that here, almost 25% on top of those who got ROSC survived due to ECPR. So ECPR is a plan B for those patients who never reach the ROSC. And of course, the predictors would be the initial rhythm and the using of ECPR, and of course the CPR time for the definitive survival. And then if we combine the data from ARREST trial and the Prague trial and look at the outcome, you can see on the right-hand side that those patients who presented with shock rhythm actually had a 19% absolute benefit from the invasive approach. So number needed to treat of 5 in 2 systems of care, which are actually very similar, the Minneapolis and the Prague system. We also look at the long-term outcome of our patients and 5 years after cardiac arrest in all 3 types of analysis, which was intention to treat, as treated, and per protocol analysis. In all those analysis, patients treated with ECPR had a benefit and with the same good neurological outcome. Also, importantly, if you look at the 180 days data, only 2 patients in both groups had a advanced neurological deficit of CPC4, and after 5 years, only 2 patients were in CPC3, meaning that those patients were dependent but still awake and able to communicate well. So this everything has led to the 2A recommendation by the currently upgraded American guidelines, and I think we can conclude very easily that ECPR should be considered for selected patients with refractory cardiac arrest. And I kindly invite you, if you like, for our Prague ECPR school, which is held every year and has almost 3 days full of ECPR talks. Thank you very much for your attention.
Thanks, Jan. I'm going to go straight to Alice to tell us about pre-hospital, starting ECPR in the pre-hospital setting, and then we've got a few more questions.
Hello again. Thank you, Jess, again for the invitation. So we're now going to move on to, is it possible to bring ECPR to the pre-hospital setting? And I'm going to tell you a little bit how we do it here in Paris and how we've been doing it now for more than 10 years. Sorry, it's not. So I think the idea of this whole webinar, and especially our two last talks, is not to tell you that one system is better than the other, but it's really that you need to anticipate the system that you're going to set up. And now that we have a clear recommendation of 2A concerning ECPR in selected patients, it's really how can you set up and anticipate things in your setting to make sure that you make ECPR available for patients who can be eligible. And this is quite a nice illustration that shows that the idea now is that we try to identify which patients are eligible. We know that we have a time frame in which we want these patients to be treated with ECPR, and you need to make it work in your system, whether it be in the pre-hospital or in hospital setting. Once again, this has been said before, but it's very important to insist on the fact that we are all very enthusiastic about ECPR and the fact that ECPR can save lives. But the idea is really that ECPR comes at the end of a very long chain of survival, and everything that we can do at the stage of ECPR is pretty much useless, as Jan mentioned, if everything is not done to save patients at the very initial phase. And this is how we try to improve patient care in our system in Paris, in the sense that we need to make sure that when a call comes into our EMS system at the SAMU, we need to make sure that the cardiac arrest is recognized as soon as possible, that we deliver telephone-assisted CPR. We make sure that bystander CPR is given with help from community response, and we have apps to make sure that people are helped and defibrillators are brought to patients and to bystanders. Make sure that patients get the best BLS and ALS support, and that we ask ourselves early in the chain if they could be eligible for ECPR, even in the pre-hospital setting. So the idea behind pre-hospital ECPR is that, as Maria mentioned, time goes by very fast when you're managing an out-of-hospital cardiac arrest patient. And the idea is that if you can get rid of the time that is needed to transfer the patient to the hospital, maybe you can try to improve or increase the probability of survival of these patients by bringing low flow durations down from what it was in Paris about 15 years ago, from 120 minutes to around 60 minutes with pre-hospital ECPR. But to make this work, you need to make sure that everything is anticipated every step of the way. And for example, pre-hospital ECPR in our system, when a call comes into the call center, we make sure that we diagnose cardiac arrest and that there is a simultaneous dispatch of every link, every person that is going to be taking care of patients, whether it be community response with the app that we have that is called Sauve Life, BLS team, mobile ICU team, which is the ALS team, and the pre-hospital ECPR team is dispatched at the time of cardiac arrest. The idea behind that is that we want the ECPR team to be on the scene early to identify potential candidates within that 10 to 20 minute time that we have to make sure that ECPR implementation is initiated early enough to make sure that patients are treated with ECPR within the 60 minutes cutoff. For this to work, of course, you need to, once again, anticipate everything. We have a dedicated vehicle in which we have every immediate available equipment that we need to ensure cannulation. This relies on a multidisciplinary team that has specific training to deliver ECPR outside of the hospital. And in this team, we have very dedicated roles as to who does what. And the important thing is that even in the pre-hospital setting, the scene can get very crowded. This is an example that was outside, but you can imagine that in a home, in an apartment, in a closed room, it can be very, very crowded, and everyone needs to know exactly what they're doing, whether it be the BLS and ALS team and the ECPR team. And you also need to identify space to make sure that everyone has a safe space to work, and make sure that ECPR implementation can be done as quick and safe as possible. So just to give you a bit of how it goes on in our team, the ECPR team is made of 3 people: the physician, who's responsible mostly for decision making, identifying patients that are eligible to ECPR with the ALS team on scene, of course. The physician is responsible for the cannulation, whether it be percutaneous or using a hybrid cut down technique. And globally, the ECPR physician is the person on scene that usually has a sort of overview of the whole scene. The anesthetic nurse is the person responsible for making sure the pre-prime machine is available and working, so that when the patient is cannulated, the machine can be connected to the patient immediately. And the idea is really that we want to anticipate on post-ECPR care as soon as the ECPR is as the pump is activated, and to make sure that we have ongoing monitoring as soon as possible. The paramedic is the person responsible for getting us to the scene, driving us to the scene, and responsible for preparing all the equipment that we are going to need for a sterile implementation. Although we are outside of the hospital, we try to be as sterile and clean as possible. And the paramedic is the one responsible for giving us all the equipment that we need to cannulate. The idea is also that we need to communicate with the SAMU, the EMS, that is going to communicate with the hospital to let them know that we are cannulating a patient and that the patient is going to be coming into the hospital as soon as possible. And of course, the idea is that we try to make things as safe as possible during cannulation, but also afterwards. And you do need to prepare a certain number of things to transport the patient in the most secure manner after that. Of course, the idea is that you do need to implement ECPR, and especially pre-hospital ECPR, in a more global strategy that includes, of course, reducing the low flow, and that's why we try to do pre-hospital ECPR. But it's also about making sure that you insert that into a larger chain, and you need to make sure that you improve patient selection and patient care. And this is what is going to help to improve patient outcome. The idea also behind pre-hospital ECPR is that the idea is not to restrict ECPR to patients that are lucky enough to be close to an ECPR center or close to a place where we can be dispatched to them. But we are able now to be dispatched outside the city of Paris to places quite far out. And we make ECPR available to patients that are further out. Of course, in these situations, you can see here that the low flow duration is much longer than what we ideally hope for, but we do have some survivors, and of course I won't have time to mention organ donation, but this is definitely a positive secondary outcome of ECPR in this setting. Once again, the idea is really that it's important to make ECPR accessible to as many people as possible, with the idea to sort of maintain equity of care. In hospital, ECPR is one solution, pre-hospital is another, and a rendezvous strategy is also something that that can be thought of when in the sense that the patient can be taken to a hospital where the ECPR team can be dispatched. And you can see here in this Australian study that the idea is really that you increase the number of people for which ECPR will be a possible treatment. Once again, you do need to think about post-ECPR care as soon as the patient is cannulated. The idea is really that once you've managed to cannulate the patient, you need to secure transport as much as possible to make sure that all the effort that you've been putting into treating this patient and trying to save this patient is not, endangered by not anticipating everything that can go wrong, because unfortunately many things can go wrong, especially during transport. So you do need to secure things and anticipate everything that could go wrong. And the idea is really that you need to optimize post-ECPR treatment as soon as the pump is activated, which means you need to start that during transportation to the hospital. And this implies trying to optimize hemodynamics, ventilation, and of course bringing the patient to a specialized center, a cardiac arrest center, where the patient will be benefiting from specialized care. And of course, thinking about treating the cause of cardiac arrest. And you can see here that in our system, for example, except if we have some kind of other cause at the origin of cardiac arrest, we will be taking these patients to the cath lab. So pre-hospital ECPR is something that we've been doing now for almost 12 years, but there are definitely many more centers doing this nowadays, and other centers to come probably very soon. So once again, it's really about optimizing every link of the chain of survival. Implementing pre-hospital is just not something you decide one day and saying, why don't we take this machine out of the hospital to see how it works. You need to anticipate the system to make sure that what you're doing is going to work. You do need to identify patients that could be eligible and make sure that what you're doing is still coherent with the timing that you're trying in which you're trying to deliver ECPR, sorry. It's definitely something that you're going to do in a multidisciplinary care, and it does rely on a lot of training and simulation. And just keep in mind that it's definitely part of a whole bundle of care in these patients. And trying to start ECPR is just the beginning of a new chain of survival. Thank you so much. And if I may, before you go to the Prague ECPR school in this autumn, if you want to come to Paris, we have our next Paris rescue team course coming up. So don't hesitate to come.
Thank you, Alice. I was just going to say, Tommaso, if you want to just tell us a bit about the care of patients who are on ECPR. So you've established flow, and we are running out of time. So just try and get us a quick highlights. May mean you have to skip a few slides, so we have some time for questions at the end. Thank you, Tommaso, and apologies if I'm rushing you.
No problem. So it is really important to consider post-resuscitation care immediately after ECPR. And okay, we know that there is limited evidence on post-ECPR care, and we know that there is a huge potential to improve outcome also by improving how post-ECPR care is provided. And one of the most frequent questions is that whether current cardiac arrest guidelines also apply to ECPR patient. And for this reason, we are working on with different scientific societies to produce guidelines that are specific for ECPR patient, and there is also an ongoing Delphi process with experts from all around the world to define consensus on post-ECPR care. And to date, we don't have any RCT specifically on patients that are supported on ECPR. And as you can see from this slide, we have a lot of intervention that we must do immediately after cannulation. And this is just the beginning, and many other interventions are required in the first few hours and few days after ECPR. And briefly, I don't have the time to follow to describe how post-ECPR care was described in RCTs currently published, but the general description is that every trial followed current guidelines for ECPR, so the American Heart or the ERC guidelines for post-resuscitation care. And all the trials attempted to follow neuroprognostication guideline, meaning that they avoided too early neuroprognostication. And one of the differences is on the use of hypothermia. So some trials did 31st, some trials initially did 33 and then moved to 36 after the publication, the TTM trial. And for example, the Inception trial that was multi-center did not get into details on how post-resuscitation care was provided and was left to each different hospital and institutional, following institutional protocols. And these are the current guidelines for post-resuscitation care for cardiac arrest patient and for neuroprognostication. And in general, there is I would say agreement between physician that and also CPR expert that most of the suggestions are applicable, including the neuroprognostication approach to ECPR patient. And probably what can be different is the management of hemodynamics in patients that are supported through ECMO that specifically may need to adjust how hemodynamics are provided, are managed. And another important difference is that patients treated with CPR typically have a higher amount of coronary lesion that probably can affect how we provide post-resuscitation care to this patient. And from a neuroprognostication point of view, there is a very beautiful study from the Prague group that analyzed specifically biomarkers such as neuron-specific enolase and found very similar cutoff to and performance similar to patient not in to the what guideline recommend. And as you can see, I think one of the interesting observations that neurospecific enolase can be higher in patient with CPR compared to patient with conventional CPR, probably reflecting the higher duration of low flow time compared to patients that achieve ROSC with just CPR. And one of the key message, if some of you is also treating for ECPR patient and patient supported with mechanical circulatory support, remember that hemolysis can affect neurospecific enolase. So just keep in mind of this effect. And as you can see, the optimal cut point, as shown by the Prague group, at 72 hours is very similar to the one recommended by the current guideline for non-ECPR patients. And I think one of the important distinctions when you treat for an ECPR patient is if the patient have recovery of cardiac function and recovery of brain function. So you can have a patient that have recovery of cardiac function and not recovery of brain function, a patient that have recovery of brain function and not of cardiac function, or different combination of that. But it is important to consider that most of the time the key determinant of the outcome is the recovery of the brain function. And patient that have recovery of brain function and does not have recovery of cardiac function are probably the patient where we can invest a lot in the following days and probably weeks and months with prolonged circulatory support. So it is important to consider that ECMO is a bridge, and we can bridge to when we have a recovery of brain function, we can bridge patient with persistent circulatory dysfunction to different approaches, and we can have, for example, a strategy of short-term temporary mechanical circulatory support, and also approaching to long-term mechanical circulatory support, such as long-term prolonged impeller support for the left ventricle, and up to implant a durable left ventricular assist device in patients that are not, for example, good candidate for heart transplantation and persist cardiac dysfunction. And as you can see, a lot of patients are dying very early in the first days. And the cause of death in this patient is frequently multi-organ failure. These are the data from the Prague study. I forgot to mention in the reference, but we have a huge proportion of patients dying from multi-organ failure. Then we have brain death, refractory arrest, cardiogenic shock, but also bleeding can occur up to that. And also, as you can see from these are data from my center, the pattern of that changes based on when it occurs. So we have an initial high occurrence of, I would say, unsuccessful ECMO flow, meaning persistent severe shock that ECMO is not able to provide flow and perfusion. And then we have a change where it occurs brain death, and then increase the multi-organ failure of patients. And also brain death is important to remember. So we have an higher incidence of brain death and organ donation in ECPR patients, so offering opportunities. Of course, if you change the criteria, can change also how many patients you have with brain death and organ donation. And it is important to remember that ECPR is affected by a huge rate of complication. As you can see here from the Prague study, bleeding again is something that occurs frequently, but also there is a complication related to CPR itself, but also to ECPR, so such as bleeding, hemolysis, and also other complications that are infection and complication of ischemia reperfusion and of the left ventricle function. And here from the ARVEST trial, you can see there is a longer list of complications with details. As you can see, even in this small trial, the complications were present in, and we must consider that this was a very experienced center, such as like the Prague study. And so if such complication occurs with such high rate in very experienced center, it is important to consider that when considering smaller center. Acute kidney injury requiring renal replacement therapy in 77% of patients, so huge amount. And this is a study showing that center volume affect survival and probably can affect also the rate of complication, but still to demonstrate. And it is important that ECPR is not just ECMO cannulation. It is a very complex intervention that requires a comprehensive care, including rigorous post-resuscitation care and treatment in a center that can offer all the treatment required from this patient, including support, including all the options of a bridge to long-term or temporary mechanical circulatory support. I have not time to cover all the aspects, but many more aspects should be covered in post-resuscitation care. Here you have a list, and probably in the next few months and years, we will have more evidence about all these aspects. And my take-home message is that we know that ECPR can save a lot of patients. It is important that now we focus also on post-resuscitation care to improve it, standardize it, and obtain better evidence for our patient. And I think that multidisciplinary management is key because these are complex patients and many different specialties are needed at the bedside to treat this patient. Thank you so much for your attention. I'm happy to take questions.
Thank you, Tommaso. We only have 3 minutes left, so I'm just going to ask everybody to give us some. You've heard things. Any sort of advice for people listening who sort of want to set up a program or already have a top tips? You can only allow 1 or 2 each. So I'm going to start with Maria and then go round. Any top tips for the audience? Or
top tips would be logistics. Have everything planned out before you start, like times and how to manage
that
it.
was more than 2, but thank you very much. Alice?
Yeah, beyond logistics, I would say training is definitely something you need to train because you can't just decide to cannulate a patient if you haven't trained about cannulation and dealing with everything else.
Right, Ingrid?
Well, to sum it up, you have to benchmark and feedback what you're actually doing. So you have to be sure that all this pre-planning and training actually is fruitful and works out.
Yeah, and I see you were saying to me earlier that you need to keep on practicing, reviewing every single case, and the improvement, the work never stops. Is that right? Okay.
Absolutely.
Yeah, Tommaso?
Collaboration with the EMS dispatch center to the ambulance with the ambulance staff and share data with them.
And Jan, any final words? You need to unmute yourself.
Sorry. Yes, every part of the chain has to be optimized. If you just make one single mistake in these cases, you're going to lose your patient. So it's really important to think on everything.
Thank you all very much. So we're coming to the last minute. There were quite a lot of questions we didn't get a chance to answer, but I think we covered most of them in the talk. So I'd like to thank all 5 of our speakers. For those of you interested, the ERC is working with EuroELSO, ECPR, USAM, European Society of Anesthesiology, European Board of Perfusion in producing some guidelines for ECPR, and they should hopefully come out sometime later on this year. It's an area of growth, and I'm sure more places will do it. I'm in the UK, very little ECPR at the moment, but who knows? And thank you to everybody for sharing their local expertise and data about the trial. So thank you all for listening, and good night.